So I did my poster project on cardiac organ transplants, and I chose this topic because I just feel like it's a lot of things that most nurses don't study that much in school, but like there's a lot of information that like we need to know about it. So basically, just going over our, let me move over, basic backgrounds. The main reasons for transplantation is heart failure, and those we can have acute heart failure, left side, right side heart failure, so forth. Signs and symptoms we're all really familiar with. You have that chest pain, shortness of breath, rapid or irregular heart rate, fatigue, weakness, rapid weight gain, decreased level of conscious and swelling in your abdomen, legs, feet, and ankles. Conditions that will weaken our heart that will lead to heart failure would be coronary artery disease and MIs or heart attacks, hypertension, faulty heart valves, damage to the heart muscles, myocarditis, congenital heart disease, abnormal heart rhythms, and you can also have sudden heart failure, which could be caused by allergic reactions, blood clots, or infection, severe infections, as well as blood clots. What I mean is in your lungs. Okay, so we realize that we have an issue. We have heart failure. You'll go in for your pre-evaluation appointment. There they will look over our heart rate survival score, and they'll use the Seattle heart failure model to determine this, and it's just basically how long you'll survive with having heart failure. If it's less than 1 to 2 years, you'll probably be a candidate for a transplant. If your exercise capacity is less than 14, which is, we see this by our peaked VO2, you'll probably be a candidate. We'll also look at blood tests or vaccine status, diagnostic tests such as chest TT, an X-ray, or pulmonary function test. We'll look at also our psychological and our social background, just because heart transplants are something that like not a lot of people have. I mean, they're in high demand basically, so we just want to make sure that if we give you a transplant that you'll be able to keep up with taking care of the heart. Just a fun fact, as of November 2021, there were 3,515 patients that were waiting for heart transplants. And this is like the most of like all like your donation of organ lists. The heart transplants are definitely the top, they're most needed, so forth. Okay, questions that we can ask, or why would I need a transplant? You would have end-stage symptomatic heart failure despite the treatment's not working. Have severe heart failure with 1 to 2 years mortality rate, non-ischemic cardiomyopathy. We can also have ischemic as well. We could have valvular heart disease, or we could just be having a retransplantation. So the transplant the first time didn't work, so we're having it again. Why can't I get a transplant? There are 4 main reasons. You have advanced irreversible liver disease, advanced irreversible renal disease, history of a solid organ or hemolytic malignancy within the past 5 years, which is just like cancer of the cancer that starts forming in the blood. Or we also have advanced irreversible pulmonary artery hypertension. Okay, so we're a candidate for having heart transplant. We'll go to our pre-op appointment. There we'll look at our history and physical. We'll also review our past medical history. We will take a pre-op EKG. We'll assess the function of our other major organs, because diabetes, high blood pressure, hyperlipidemia, and a renal dysfunction are all major signs that we have a high risk of dying after a heart transplant. We'll also assess for adequate preload of the heart, and we'll also check our glucose levels because we want to make sure that we don't have diabetes. And we'll also check labs, especially our CBC, coagulation, and chemistry. Okay, so everything's good, everything looks great. We'll have our procedure. Patient will be under general anesthesia, possibly a ventilator as well. The chest is broken open, the heart is placed on bypass, then it's stopped, it's replaced, the new heart's put back in, we sew it in. Vessels are all connected, bypass is removed, heart is shocked and restarted, pacemaker is inserted, chest is sewn back together, chest tube is inserted to drain all the extra blood, and a sterile dressing is applied. Just a couple fun facts: 85 to 90% of patients live 1 year after the surgery. 75% of them live 3 years after the surgery, and the survival rate drops 4% each year after the first year. So if the first year, if you had a survival rate of 86%, that means like the second year you're gonna have a survival rate of 82%. Just post-op after the procedure. Post-op, yeah, after the procedure. We want to maintain an adequate preload and use BP monitor to monitor the volume status. We also want to focus on pain control since these patients will be in a lot of pain because they just had major surgery as well as their heart was broken open. We want to ensure proper infection, prophylaxis. We want to continue the immunosuppression therapy, and we want to prevent DVTs as well. We don't want any clots. Okay, lastly, we can talk about our complications. We can have chronic kidney disease. Our organs can reject it. They just reject the heart. We can have a graft dysfunction. Sorry, let me just look at my notes. I have graft dysfunction is normally a sign that we'll need to have a retransplantation, as well as a cardiac allograft, vasculopy. Sorry, I did not pronounce that correctly, but that's basically just when there's a thickening and clogging of our arteries, and it's very hard to treat, and the person will probably die if they have this. And basically 10 to 20% of people have it within their first year of having the surgery, and also infections another complication. But anyway, that's my poster. Let me show you, maybe hit a little bit more up close since it's hard to see. We have our background, pre-evaluation, questions. We have our post-op and pre-op down here, procedure, and my favorite part, complications.